The in vivo PKD models and reage score distributes knockouts and conditional rodent models for ADPKD, ARPKD, and hepatorenal fibrocystic disease. We also distribute tissues from the most popular mouse lines with different degrees of cystagenesis. We are developing 2 new mouse models with a SNAP tag in polycystin 1 and a halo tag in polycystin 2 that will be available soon. Do you need a new animal model to move forward your research? Contact us and we will help you to design and develop a new mouse model.
PKD RRC offers multiple cell models for in vitro studies. These include human PKD and normal human kidney cells, as well as biomaterials such as frozen and fixed tissues, primary and immortalized mouse, normal, and PKD cell lines, embryonic kidney cultures, and mouse kidney organoid cultures, allowing investigators to test specific hypotheses and validate drug responses in a controlled environment.
Our antibody and vector core provides the following reagents. We provide various antibodies to polycystin 1, polycystin 2, or fibrocystin. We provide a PKD1 antibody validation kit for using our PKD1 antibodies. We also provide a human PKD1 cDNA cloning kit for introducing mutations. Lastly, we provide various PKD vectors, including expression constructs and CRISPR-Cas9 plasmids.
Do you need to translate your PKD research and make it clinically relevant? The Clinical Resources and Biomaterials Core is here to help. We have clinical data, blood and urine biospecimens, kidney tissue, and primary cultured cells from patients with ADPKD, ARPKD, and other hepatorenal fibrocystic diseases. To get access, just go to our website, fill out an online request form, complete an MTA, and see how our core can advance your research program to the next level.
Okay, so I think we'll get started now with our next session, latest advances in pediatric PKD, and our session chairs are Melissa, and I'm not going to try to say your last name, Melissa, and Ashima Gulati. Melissa is from the Pediatric Nephrology Rocky Mountain Pediatric Kidney Center, and Ashima Gulati is an assistant professor at Children's National. So I'll go ahead and turn it over to the session chairs.
Ashima, you're still muted.
All right, good morning and welcome back to the second session of the day, latest advances in pediatric polycystic kidney disease. And it is an absolute pleasure to introduce the first speaker of this session, Max Liebau. Dr. Liebau is the head of translational pediatric nephrology at the University Hospital Cologne in Germany, and currently also serves as the chair of the Inherited Kidney Disease Work Group at the European Society of Pediatric Nephrology. Dr. Liebau really combines his clinical pediatric and cellular and molecular biology training to follow a translational research approach to study genetic kidney diseases with a special focus on the autosomal recessive form of PKD, which we will all agree is one of the most challenging conditions in pediatric nephrology. Amongst other initiatives, his group has coordinated the international ARPKD registry study, and we really look forward to his talk on the natural history of ARPKD, insights from the international ARPKD registry study. Dr. Liebau.
Thank you very much. Thank you for the invitation. I hope you can see my slides now. Can you see my slides? I suppose yes. Right, thank you very much indeed. Right, thank you very much again for the invitation. It's a great pleasure to give this a talk on ARPKD and some of the data we obtained in the ARegPKD study. So this is my conflict of interest. And just very briefly, I'm sorry. Very briefly, this is about ARPKD. You all know about it. It's the rare pediatric form of PKD. There's one main gene that is involved, PKD1, encoding the cilia-associated transmembrane protein fibrocystin. Although variants in other genes have been described with an ARPKD-like phenotype. The phenotype is characterized by massively enlarged kidneys due to ubiquitous microcysts initiating in the distal nephron collecting duct. And as you can see here in this MRI picture or in this clinical picture, this can lead to massive abdominal distension. In addition to the kidney phenotype, there's always the liver involved that is due to a defect in bile duct development and can present with congenital hepatic fibrosis or Coriolis syndrome. And additional extrarenal manifestations include pulmonary hyperplasia, hypertension, etc. So it's a real clinical challenge. Even more is there's a lot of clinical variability that we do not really fully understand, and that as of now, there's no targeted therapy. And part of this is because there have been difficulties in establishing a primary endpoint for clinical trials. So there's been very important work by various groups. So Lisa Gay-Woodford, for example, described the clinical experiences in the US, and what is just shown here is a summary of the patient survival in this cohort. And as you can see, there's this steep decline in the first year of life, some very severely affected neonates that pass away. Same was found in the Mayo cohort described here, and also in the European cohort that it was described by Carsten Bergman and others. More recently, again, a study by Lisa calculated that about 80% of the neonatal children survive these days, also showing that still 20% of these kids pass away. So it is a very, very severe disorder. So despite this important work, there were some questions that are important. So can we identify these high-risk subgroups that show the severe kidney disease progression? Can we identify high-risk subgroups for liver disease progression? What would be the disease cause of such cohorts? And can we find explanation for the always described variability? And so this is a bit different from the previous session. We're here much more focusing on the clinical workup of these cohorts. So about 10 years ago, we said, okay, what we need is again a deeply phenotyped cohort that we follow longitudinally to look at the long-term clinical causes, to look at what people are currently doing in clinical work, and to lay the foundation for the potential identification of clinical or biochemical risk markers. So therefore, we set up this ARPKD registry study that was supported by various scientific societies. And also there's very close collaboration with, for example, Lisa Gay-Woodford in the US, but also initiatives in other countries. And funding is purely from public sources. So what do we do in the registry? So we allow pro and retrospective data entry, and then we have a basic data set that sort of covers the clinical history until diagnosis, the family history, genetics that may have been done, etc. And then we ask for about one clinical follow-up visit per year, or the time frame is flexible, where we look at the development of the kidney phenotype, kidney function, laboratory markers of the liver, ultrasound markers of the liver, findings of the liver, etc. So where are we right now? More than 100 centers have registered in Europe. This is mainly a European thing. About half of them are actively contributing, and you see down there the different societies and funding agencies that contribute to this and make it possible. And we have, as of yesterday, 723 patients that have been included, with more than 580 being active right now, with more than 4,000 independent visits. And about half of them have genetic findings. So I thought I'd show you some of the data we've learned, but also some unpublished data. So here, what we see here is kidney survival in our overall cohort, and we define kidney survival really very strictly as the start of kidney replacement therapy, so either dialysis or transplant. And what we see is that, again, there is this steep decline in the first year of life, as expected by the most severely affected children, the ones that for us as pediatric nephrologists really are a huge clinical challenge. And then there is this progression that is sort of continuous, and we end up with about 50% kidney survival by the age of 20. And this is sometimes a surprising mark to some listeners, because most people will sort of think of ARPKD as always being associated with kidney failure straight away. This is not the data that we see, and this is also not the data that was previously published. Our data fits to what other groups have previously found in smaller cohorts. So within this group, can we identify a high-risk subgroup that could potentially have most benefits from therapeutic intervention? So here we had our first study when we had 385 children in the registry, and what we did is we just compared the children that started dialysis in the first year of life to children that did not require dialysis in the first year of life. Why did we choose the first year of life? Because dialysis in this early time frame is still a clinical challenge, and then with a year or a year and a half, the children usually get to that weight where they can undergo a transplant. So we compared prenatal, perinatal, and postnatal information, and this is a very busy table, but I just want to focus on some aspects. There were some differences between the subgroups that were really very prominent. One was the difference between in oligo or anhydramnios, so little or no amniotic fluid detected antenatally, and this was a very high percentage in the children with dialysis in the first year of life, and a quarter in the ones without. Another interesting aspect was the APGAR score. That is the score that is taken right after birth, where you see how well the kid adapts. And again, the ones doing more poorly were found in the group with more dialysis. And then obviously also these children were admitted to NICU more frequently. So neonatal intensive care unit. We took all the data to a multivariate model and identified independent risk factors associated with KRT in the first year of life. And there were strong hazard ratios, again, for oligoanhydramnios, for prenatally enlarged kidneys, and for assisted, or the need for assisted breathing and or ventilation after birth, again, fitting what has been found, for example, in the American cohort. We then took the data and developed a model, because we were thinking, okay, this is helpful, but it would be even more helpful if we could tell antenatally what the risk would be, and whether, it would be very important to have that kit delivered in a tertiary center, for example. And here we developed a model and looked at the probabilities for kidney replacement therapy in the first year of life, just based on 3 easy to detect clinical markers that can be seen just with an ultrasound examination. So we looked at enlarged kidneys, renal cysts antenatally, or again, oligoanhydramnios. And what we see is that the risk increases with more markers. If you look at just enlarged kidneys, the probability was rather low. However, if you had oligoanhydramnios and enlarged kidneys and renal cyst, about 1/3 of the children required dialysis in the first year of life. Also meaning that, according to this model, 2/3 would not need it. So antenatal sonographic detection of kidney enlargement, renal cysts, and oligo or anhydramnios may help to identify a high-risk cohort for early dialysis dependency in ARPKD, and also a cohort that might benefit from treatment. And this is what actually was the base for this first phase 3 trial that's going to be launched, or has actually been launched in first centers in the US, that will look at an effect of tolvaptan on the need for dialysis in these young children, and it will include children between the age of 1 and 3 months that fulfill these high risk parameters. And the primary outcome will be the percentage of children that will start dialysis in the first year of life. So a first phase 3 trial in ARPKD. So second, what about the liver? And here we looked at genotype-phenotype correlations. Just very briefly, what we did is we sort of cut the protein into 4 pieces because we also wanted to have it easy to use in clinical daily life. And these 4 sections, were chosen because of the exons and the protein domains, and because of the data that was previously published on the distribution of variants. Fitting to what others have found, we see that the truncating but also the missense variants can be seen all over the extracellular part of fibrocystin, with the more common variant T36M that was also previously found to be more common. So how does that relate to the phenotype? Here we started by looking at the type of variant first, and we compared patients with 2 null variants. With patients that either had 2 missense variants, shown here in red, or a null and a miss, etc. And we see that the blue patients, the ones with 2 null variants, progressed to kidney replacement more rapidly. It's interesting to see these patients at all, because previously, until a few years ago, it was believed that these patients would not be viable, but obviously there has been progress in neonatal intensive care medicine. Same was true for liver phenotypes. So time without substantial hepatic complication that we defined as kidney or combined liver and kidney liver transplant or combined liver and kidney transplant, a variceal bleeding, or a need to do surgery for portocaval shunting, and again the biallelic nodes did most poorly. Is the localization of a missense variant important? Here it seems to be the case. I'm sorry, I saw some information here on the slide. It seems to be the case. So we found that patients who either had 2 missense variant or 1 null and 1 missense variant affecting this second part of fibrocystin had a better renal course than the other cohorts. How about the liver? Here we see something else. Here we see that variants, patients with 2 missense variants in the C-terminal part, or a truncating and a missense variant in that C-terminal part, do more poorly and progress more rapidly. Numbers obviously still remain limited, but for such a rare disease, they are quite okay. So what's the disease cause of such cohorts? We started with the kidney phenotype. TKV in ARPKD obviously has a very different role from TKV in ADPKD, but we looked at the first documented height-adjusted estimated total kidney volume in ARPKD and found that patients with biallelic null variants had larger kidneys than all the other subgroups. We also found that patients with larger kidneys had there was a tendency to lower eGFR values, although there was a lot of variability. And again, that fits to what, for example, the NIH cohort has previously shown. However, what we did see is that the ones with the largest kidneys showed the poorest kidney survival early in life. So what we did here is we looked at different quartiles of the kidney volume. So the blue patients are the ones in the largest TKV quartile in the first 18 months of life. And what we see is that here kidney survival was poorest compared to the other groups. And this was not because they would lose kidney function more rapidly, but it seems that they did not get to that improvement that we see in healthy kids and in other diseases. So usually kids will improve their kidney function in the first year of life. What we did here is we compared the course after the first year of life of the eGFR of these quartiles again, and we see that the rate of decline doesn't differ an awful lot, but they just start from a lower level. So can we find explanations for the observed variability? Here we looked at sibling findings in our registry. It was previously shown that there is variability in ARPKD, which was mainly defined as survival differences between siblings. So we had 35 siblings in our cohort. Just one passing away. So this is a cohort of siblings of neonatal survivors. And in this cohort, we found a bit more limited variability, mainly 3 siblings with major differences in kidney function that would not be explained by age. So that in our view points to a relevant role of underlying genetics to the cause of kidney function in these patients, although minor differences obviously were seen more frequently. Also for liver disease, the differences were not terribly striking. Again, one family where there was quite a difference between the ages at diagnosis. This was also a family where there were a lot of differences in the kidney function, but here data remained more limited, I should say. So there's a caveat at this point.
3 minutes.
In general, we are now looking at liver disease a bit more in detail. Again, this is unpublished data where we look at the time to event analysis. So each dot is like the first documentation of the indicated clinical finding in our registry. And you can see here the numbers, and this is the median age for the corresponding finding. And you see that the main complications like bleeding or the need for a transplant, there we find a median age of 8.2 or 8.6 years. So this is a severe cohort, obviously, but it's a bit later than kidney findings. This is the general Kaplan-Meier survival without substantial hepatic complications, and as I just said, it's not as steep as the kidney curve. Still, 80% survival without substantial complications by the age of 20, also meaning that 20% had these severe hepatic complications. And that fits to a finding that we had in young adults, where we did a cross-sectional study where liver-associated findings were very common, or the numbers remained very small, both on sonography, on ultrasound findings, but also on clinical symptoms. So there are limitations that need to be kept in mind. This is real-world data. There are variable follow-up periods. There's partially missing data. We did try to standardize a lot of things, but obviously this is limited in this setting. We have a partially genotyped cohort. There may be selection biases because these are mainly tertiary pediatric nephrology centers contributing. So it may underrepresent liver disease, it may underrepresent disease causes that go well, maybe into adulthood, and we may miss most severely affected children that pass away because the centers may not want to approach these families, and only weakly affected patients because they may not make it to tertiary centers. And with that, I want to summarize this emerging data from ARegPKD on the clinical causes of patients with ARPKD, and that may be helpful for the identification of patients with a high risk, for example, for kidney disease progression. Early intervention could be of particular relevance for kidney disease in ARPKD, and the first phase 3 trial has been initiated. Liver disease may become increasingly important as more children now survive and as the disease progresses. And with that, I've come to an end. I want to thank collaborators all over Europe and in the US, funding agencies, and I'll be happy to take questions.
Thank you, Max, for taking us through this nice journey of the registry data so far. I think we have 2 questions in the chat. Have you found any pancreatic abnormalities in your ARPKD cohort?
We have found single patients with pancreatic abnormalities, yes. We have also some single cases that look like pancreatitis, but it's not a very prominent finding.
And I think there's a comment and a question from Dr. Gray-Woodford. This is beautiful work. In your data set, do you have information about neurocognition and behavior?
Yeah. So we thanks, Lisa. Yeah, we do ask about it. We did a more detailed workup, and I did not show it on patients that had undergone very early bilateral nephrectomy, which sometimes is done in the centers. And in this cohort, we found a lot of neurological complications with blindness, parenchymal bleeding, etc. So really a very strong phenotype. We also ask for neurological phenotypes in general in the cohort, but not in as much detail as, for example, for the kidney, and have not yet come across a lot of descriptions. Might still be worth digging into it more deeply. Yes.
And I think the work on the very early bilateral nephrectomies leading to adverse neurological consequences has really informed the field as to how to think about it. I just wanted to make a quick comment on like what your thoughts are on how the registry is equipped to handle collaborations between pediatric and adult nephrologists now that there is increasing recognition that young adults and adults with mild kidney phenotypes who really may present to adult colleagues. And I think that's very important to be a part of the natural history and also for genotype-phenotype correlations.
So I fully agree. I could not agree more. Yeah, it's very important. So this is very frankly speaking, it's a bit easier to work with the pediatricians than to work with the adult nephrologists. No offense to anyone, but it's just the infrastructure is just much more easily established in Europe, and we are very open to collaborate with the centers, especially in Europe, because this is easier for data protection reasons. Because I fully agree, young adults, I think there is a new field coming up, and with more genetics being around, I get more and more calls from colleagues saying, okay, this, I would have never thought this could be ARPKD, but this patient has PKD1 variants, and no other important genetic variant. And it looks like a small kidney with some cysts, so there may be something hidden.
Yeah. And I think just one last question just came up to the same effect. I think there's a question: are there many individuals who are at the older end of your cohort who were not diagnosed until much later in life?
So we do have some patients. Most of our cohort, I would say 3/4 or something like that, are either diagnosed antenatally or in the first year of life. So it is mainly pediatric driven and tertiary centers. Yeah.
Okay. So yeah, I think we are all are on the same page that for the real success of this registry, it's equally important for both pediatrics and adult nephrologists and also for hepatologists to be apprised of the registry and contribute to it. Thank you, Max. And with this, I will go ahead and introduce the second speaker of the session, Sophie Saunier. Dr. Saunier heads the lab of hereditary kidney diseases at the Imagine Institute in Paris. Dr. Saunier's long-standing work has been in the field of renal ciliopathies and specifically nephronophthisis, and it has led to identification of several genes underlying nephronophthisis and has also led to successful generation of both cellular and zebrafish and mouse animal models of nephronophthisis. And more recently, and I think what is more exciting is that Dr. Saunier's group has been working on developing new therapeutic approaches for nephronophthisis, where traditionally, as we all know, the only available treatments have been dialysis and renal transplant. So we are eager to hear her talk on the new therapeutic concepts from nephronophthisis and related ciliopathies. Dr. Saunier.
Thank you very much, Ashima. Could you hear me well?
Yes.
Okay, so it's a real pleasure to be here with you today. I'm not PKD person, but as you heard, I'm working on the very common renal ciliopathy that is a nephronophthisis. So you know, of course, that ciliopathy is a rare and severe genetic diseases caused by ciliary dysfunction, as was mentioned, is individually rare but collectively frequent. And the common cause of morbidity and mortality is the end-stage renal disease. There is no treatment available, as you mentioned already, and except dialysis and transplantation. And as main renal ciliopathies in this spectrum, there is the pediatric form that is nephronophthisis that I'm working on for many years now. So nephronophthisis is a chronic tubulointerstitial nephropathy with an autosomal recessive mode of inheritance. It's characterized by polyuria and polydipsia, and contrary to the PKD, generally it's there is a development of massive interstitial fibrosis with or without cyst, and the kidney are usually at normal or small size. It's a major cause of end-stage kidney disease during childhood and young adults with a mean age of 13. But you can see that there is a very early form with infantile form before the age of 5, and it can go through the adult age. We have here in the cohort out of 42, but it can go to 65. And as the ciliopathy spectrum, there is in half of the cases in this cohort in Necker, there is extrarenal symptoms, and the main one is retinal dystrophy with the Saunier-Laken syndrome, but also neurological symptoms, skeletal symptoms, and hepatic fibrosis. So there is a large genetic heterogeneity in these nephronophthisis and associated syndromes. Today there is 23 genes that has been identified, of course, maybe more, probably more. And in the cohort here in Necker, so it's about 1,200 patients, families, we have molecular diagnosis for 60% of the cases, and you can see that NPHP1 is the major cause of nephronophthisis. This is due to common deletion that encompasses the genes, and that is a frequent event compared to the substitution mutation in the other cases. But all these genes encode proteins that are located function at the primary cilia, as you can see here. And NPHP1 is forming complexes with the other NPHP at the transition zone, and it's play an essential role in controlling the ciliary composition and ciliary signaling. So in order to gain into the mechanism and the pathophysiological understanding of this disease, recent work from Amandine Viau, that is a scientist in my lab and that was working in Freiburg in Wolfgang Kuhn's lab. She did some comparative analysis of two NPHP mice models GLIS2 and LKB1 that is specifically deleted in the kidney tubules with a KSP3. And she identified a common signature of specific cytokine that are upregulated in these NPHP models. So in order to see if this signature is correct also, it exists also in human, we used our collection of urinary renal epithelial cells that we collect from urine from patients with nephronophthisis. And she showed that this signature on this specific cytokine was also upregulating the supernatant of the urine. Interestingly, this inflammatory event in the context of the nephronophthisis was also happier also to us when we perform single-cell RNA-seq from urines from patients with NPHP1 compared to control, where we saw an increase of specific increase of immune cells in the urine of this patient. So finally, she demonstrated that in the kidney biopsies from patients with NPH, there were also this recruitment of macrophage T cell, but also specifically neutrophil in the kidney biopsies from these patients. So this ended up to be really a signature on the process that is altered and associated with the nephronophthisis along with the PKD. So as Ashima present, we are focusing now on therapeutics concept for nephronophthisis, and as it's a ciliopathy, we want to know if we can target the cilium. And for that, we used a cell-based approach with FDA approved drug screen library with that is a press week with 1,200 compounds, and we used two readouts. We used cells that were invalid knockdown for the main genes NPHP1, IMC-D3, and MDCK7 that are really common cells to study cilia and epithelial defect in this disease. And we identified 51 compounds that were able to rescue both phenotypes, increase cell migration, and ciliogenesis defect in these cells. So out of these 50 hits, we selected 11 that was really based on their pharmacological properties, and that were relevant also for the disease. So after the next step was to really validate these 11 hits in a specific, more accurate models, and that's why we come back to the AREG cells. So this was, we have a big collection at Necker of the from the urine of from healthy controls, patients with NPHP and PHP1, and also from CKD patients that are non-ciliopathy. We collect primary cells and we immortalize those cells using Grand-T SV40 thermosensitive vectors in order to be able to screen and manipulate easily these cells from patients. So with these cells, we are able to design some specific readouts: ciliogenesis, cilia length, cilia recomposition, epithelialization, transcriptomic profiling, and EV proteomics. So today I will show you especially what we apply for ciliogenesis. So we set up a semi-automatic quantification of the ciliogenesis on Opera using the microscope Opera and the software Harmony. Like that, we were able to quantify the percentage of ciliated cells in NPHP1 patients, in controls, and in CKD patients. And it ended up that NPHP1 patients are significant decrease of percentage of ciliated cells in those conditions. So this is what we used to validate the 11 hits that we previously identified. And like that, we were able to highlight a very significant and very very good, very good compound that is a PG1 or prostaglandin type 1 that was really improving the ciliogenesis from twofold. So PG1 is an analog of the prostaglandin and is known to target 4 receptors, PGER, 1 from 2 to 4. And as you see here, in the AREG, using RT-qPCR, we were able to see that one of the main predominantly expressing EP receptor was EP2, and with a less extensive EP4. And these 2 receptors are G-coupled PCR receptor that are G-alpha-S activator and that increase cyclic AMP. So it's also interesting to note that EP4 has already been known to improve and increase ciliogenesis via cyclic AMP in zebrafish and other model. And indeed, EP4 has been localized to the ciliary membrane and not EP2, but we have shown in the lab that overexpressing an EP2 GFP is able to go to the ciliary membrane. So we further continue our exploration with EP2 agonist and PG1 agonist. And we explore some more patients with NPHP1, and we see that both PG1 and agonist of EP2 were able to significantly and very nicely restore the ciliogenesis in these cells. So most probably this activation was through the adenylate cyclase activation and cyclic AMP and PKD. In order to see if the restoration is not only for ciliogenesis, we check the ciliary composition, and in particular, we know that adenylate cyclase 3 was decreased in NPHP1 model compared to controls, and we show that the treatment with PG1 was able to restore to a similar level the adenylate cyclase 3 positive cilia in these cells. So in order to be sure that the ciliogenesis effect was due to the activation of cyclic AMP-PKA pathway, we pursue this investigation. And indeed, we show that upon, so it's alprostadil or PG1, we have an increase of production of cyclic AMP in NPHP1. And this is similar to forskolin activation. And in the same line, we have also shown that forskolin as also that is activating cyclic AMP and PKA also have the same events, same effect on the ciliogenesis. So to get a little bit further, what's going on downstream the activation of EP2 and EP4, we have so an increase of cyclic AMP, PKN. What is known is that P24 KIP1, that is a key actor of the quiescence, and that by increasing his activity will block the cycle and induce the cilia elongation and ciliogenesis was decreased, I mean, in NPHP1 and was decreased with, was increased, sorry, with the PG1 treatment at the similar level than in the control. Another activation of the, another effect of the cyclic AMP-PKA is the decrease of ROA and activation of ROC that is also known to block the that is also known to block the cilia elongation and ciliogenesis. So here we show that the treatment will decrease ROA activation and ROC inhibition. So this is the mechanism we highlight in the UREX. But in order to get more into the molecular mechanism, we perform a broad transcriptomic unsupervised transcriptomic analysis, and we compare transcriptome of NPHP1 URECT plus or minus PG1 treatment. We identified 128 gene dysregulated in NPHP1 that was invertedly regulated in the, with the treatment, and highlight the unreached signaling pathway that were downstream. And what we can see is that PG1 treatment really regulates the actin cytoskeleton genes, the extracellular matrix and receptor interaction, some metabolic pathways, mTOR signaling, and cyclic AMP signaling. So this was, we select 11 of these, some of the targets of these main pathways, and we show that in general, PG1 modulates the extracellular matrix gene down, and the actin and the cyclic AMP gene down, and upregulated the fatty acid oxidation and the mTOR and the HOC pathway. So interestingly here, you have, I highlight the LAMC2, that is an extracellular matrix, where you see that in NPHP1 cells, like in PKD cells, there is overexpression of this protein that is down regulated, or down, the expression is down following the treatment in this cell. So now the idea was to see, to validate the beneficial effect of this treatment in a model in vivo. So there is no good model for NPHP1 mouse that was exist. So we generate one cow mice using a CRISPR-Cas technique approach, where we delete, we perform an homozygous deletion of the ATG in the exon 1. And this lead to the total absence of the mRNA transcript, but also the protein, as you can see here in this Western blot, or you can see here in this immunofluorescence here in the kidney of the wild-type mouse, where you see nicely that NPHP1 is at the transition zone at the base of the cilia, and where you knocked in the cow, you have no NPHP1 anymore.
3 minutes.
Okay, so just go quickly. In this mice, there is a male infertility and early onset photoreceptor degeneration, but we have also a late onset renal lesion with tubular dilatation in the distal part of the nephron and abnormal cilia length. And this is really reminiscent of the renal lesion in the human with distal connecting tubules and that are dilated. So we perform IP intraperitoneal injection from 1 month to 5 months every day. And we analyze the kidney lesion, and we can see very nicely that there were a diminution, a reduction in the dilatation index in numbers and area after 4 months of treatment. And it was the case also for the cilia, where cilia length was increased, like in the human, in the NPHP1 tubule from mice, and they were restored to normals. If we go back to the, profiling, RNA profiling, we can see that marker from pro-fibrotic marker was upregulated in NPHP1 and was decreased with the treatment, and the global RNA signature that was also disturbed, deregulated in NPHP1 was also restored after the treatment. We can check quickly, the main regulated pathway are the same than in the Urex. You have cell cycle, microtubule cytoskeleton, ECM organization, and cytokine response, like evocative of inflammatory defect. So here, I have no time, but we also showed that in zebrafish, the restoration was occurring for the PG1 treatment. And finally, as the cilia is everywhere, and especially impacting also the retina, we check if the specific agonist EP2, that is known to be EP2 mainly expressed in the retina, was also efficient in the retina. Of course, I told you that the defect of the retina is very severe, with a complete loss at P21. So we treated every 3 days with the agonist EP2 by IP, the mice from P6 to P21, and we show a partial maintenance of the outer layer of the photoreceptors, and really restoration, partial restoration also of the light perception with an improvement of the magnitude of the beta wave. So to conclude, this is a really promising results. From the small molecule cell-based screen, we identified agonists of cilia-related signaling pathway, namely prostaglandin E2 receptor agonists that were able to rescue ciliogenesis in NPH patient-derived kidney cells. We show the mechanism based on our models, and we also validate the efficiency of this compound in animal models, especially in the mice, cow and PHP1, with PG1 that rescue tubular dilatation and cilia elongation and pro-fibrotic signature, and with EP2 agonists that partially rescue retinal degeneration. The idea now is to increase and extend the potential impact of this EP2 and PG2 agonists in other Urex from other patients with mutation in other NPHP or renal ciliopathy genes, and also other model with NPHP, and to specifically check if the inflammatory signature and cytokine signature we identified where it can be rescued also by this treatment. And finally, I would like to thank, of course, all the people that participate to this work, of course, my lab, and also the company Medecia that help us to identify these molecules, and all the pediatrician, of course, and the adult nephrologist, and my collaborator. Thank you very much.
Thank you for the great presentation of this really promising work in nephronophthisis. I will, in the interest of time, take one quick question from the chat. Where do you think is the signaling occurring that you are pharmacologically targeting with PGE1 and the downstream signaling? Is it in the cilium or the cytoplasm?
Yes. So this is a good question, because EP receptors are also at the membrane, right? So it's really possible, and of course it should be possible, because what has been shown is that cyclic AMP PKI will activate the IFTB trafficking enterograde transport and improve the ciliogenesis, but the receptor are, we think, at the apical membrane. So you can completely imagine that it passes through the cilia, but if it occurs also through the adenylate cyclase, you can imagine that there is both. But yeah, I would say that it can be really outside the cilia.
Another question that came up is, do you know if the PGE1 agonist has any effect on sperm function in the NPH1 knockout model?
Attends, excuse me, attends, let me, sorry, could you say that again?
Does the PGE1 agonist has any effect on sperm function in the NPHP1 knockout model?
Yeah, I don't know. We haven't checked.
Okay. So just to wrap up this, I would like to hear your thoughts on what your thoughts are on the are there new genes to be discovered in nephronophthisis with over like 20 genes already present in OMIM, yet like 40% of the nephronophthisis remains genetically unsolved? Do we think there are new genes, or do we think this is all overlap between different associated syndromes?
Yeah, so this is a very good question. I think that now, and what our lab is interested in is all the non-coding variants and all the events that can really affect genes that, the known genes. I think that there is a bunch of genetic variation that are not identified because of the, we are performing exomes and things like that. So hopefully whole genome will solve these cases, but it's really difficult to assign one variant if you not couple your study with transcriptomic analysis and deep transcriptomic analysis. So I would guess that part of the mutation that are not identified are, on the non-coding and specific, rearrangement variants. And maybe you have also some cases that phenocopy the mechanism we are highlighted here, and that, in genes that are in this signaling pathway that we are highlighting as well.
Thank you very much. And with this, I would request my co-chair, Melissa.
Thank you.
Use the next speaker.
Thank you. So our next speaker is Djalila Mekahli. Dr. Mekahli is a staff member at the Department of Pediatric Nephrology and Organ Transplantation of the University Hospitals Leuven, Belgium. She is a professor at the University KU Leuven, Belgium, and leader of the PKD research group focusing on ADPKD in children and young adults and aiming to find novel early biomarkers for ADPKD and unravel the proximal molecular events that are essential in the progression of ADPKD. She is the principal investigator of the unique International ADPKD Children Registry, which hopefully we'll hear more about. And she is the co-chair of the work group for autosomal dominant structural kidney disorders, including ADPKD and TSC, from the European Reference Network for Rare Kidney Diseases. And she's going to give us an update on research in pediatric ADPKD.
Thank you, Melissa, for the introduction. Thank you, Thierry and Lisa, for inviting me for this very exciting symposium. Are you seeing my slides?
Yes.
Yeah, that's good.
Yeah, because I don't see you anymore. Okay. So I would like actually to present you today mainly clinical data on the research of pediatric ADPKD. Here are my disclosures. And I would like to start actually by saying that the management of children in families with ADPKD is really a matter of medical controversy where we are facing currently. So patient and caregivers' beliefs, attitude, and perspective on pre-symptomatic testing in ADPKD is really conflicting. So, and this controversy is because a lot of patients have a fear of having financial burden, limiting their work opportunity, or having difficulties to have an insurance. Also, because we don't have a really certainty on the clinical phenotype with this intrafamilial variability, we cannot actually be sure about the progression in patients. And a lot of patients are also reassured because they are asymptomatic and not feeling anything. However, the other caregivers are thinking that making the diagnosis in early patients will really give early detection of treatable comorbidities and allowing the families for acceptance and resilience. When asking patients on the ADPKD feeling, we see that in ADPKD, patients are having an increased psychological stress and depression. And the main 3 points that rise from this survey is that they are feeling guilty because they might pass the disease to their children. They are concerned about the end-stage kidney disease, and they are a lot of concern because they might have problems in their life having ADPKD. So I would like to share with you what Dr. Grantham said in writing a very nice rationale for early treatment of PKD, showing that Dr. Grantham was really very early in his thought and in his research. And in 2015, he wrote that indeed the pediatricians are mainly alert on ARPKD, the disease which is much severe, as Max Liebau showed us earlier. And saying that although much more common, asymptomatic children with ADPKD usually goes unrecognized. However, he stated that indeed evidence is mounting that renal injuries commence with the formation of the first cyst, which might be already on prenatally, and that the medical world has been slow to recognize this fetal cyst formation that can be very important features in ADPKD. Consequently, he concludes that it is appropriate to alert pediatric physicians that they will be treating young patients with ADPKD in the years ahead. So indeed, ADPKD is mainly known with this phenotype of adult onset and reaching end-stage renal at late disease. However, we have really another spectrum with early or very early disease manifestation, reaching end-stage disease by the age of 30 or 40 years of age. So the last year, it has been the pediatric community, and I have been doing a lot of research in my lab on ADPKD in children. And I think that there is now really a change of thoughts in the presentation over the entire age range. So ADPKD children are coming to our clinic because they are presenting with symptoms, sometimes with severe prenatal diagnosis with mimicking ARPKD and presenting sometimes early hypertension and early decrease of GFR. However, these cases are very rare, and we need to take them in consideration very early. The second group that we are seeing in our clinic is the intentional diagnosis, where a child is coming for another symptoms, and when we do an ultrasound, we find renal cyst, and the diagnosis of ADPKD is then made. The third group, which is the main controversy, is the intentional screening in the context of familial history. So let's focus now on the patient, on the children in ADPKD and their clinical manifestations. So they can present actually with such as the adult with urinary tract infection, decrease of urinary concentrating, hematuria. However, the extrarenal manifestation in childhood are really very rare. We almost no see liver cyst, no lithiasis, no intracranial aneurysm, and we actually don't even screen for this. But the main manifestation in ADPKD children are actually hypertension and proteinuria. So a meta-analysis recently showed that ADPKD children might present with hypertension in 20% and also with prevalence of proteinuria. And Melissa have done also an incredible work in the Colorado cohort showing actually that ADPKD patients and children specifically can have an increase of left ventricle mass before actually having a serious hypertension. So even with the borderline high blood pressure, they represent a cardiac phenotype. Also, it has she showed that actually hypertensive children have really a quicker and a rapid progression of TKV. So since years, there is lots of research in adult patients with ADPKD, and they succeeded actually to define some disease severity, mainly related to the patient, the BMI, the age, male sex, but also to the genetics. The PKD1 truncating have a severe phenotype than the non-truncating, and PKD2. It has been also validated that the height TKV in adults might be a surrogate for progression. Hypertension and other symptoms are also being selected to be important for disease severity. And actually, they succeeded to have prediction models to define adults with rapid progression risk from those with a more slow phenotype. However, in children, we don't have these prediction factors. All our studies are mainly based on small cohorts, and the difficulty, contrary to the ARPKD, where the end-stage renal disease is actually reached in childhood, ADPKD, we have difficulties to find an endpoint, and we don't have actually very, very long-term data. So to assess the risk of ADPKD in childhood, we are actually facing really a lot of hurdles in children research. So the eGFR is not reliable because they have all a normal GFR. TKV is not yet validated. There is also the normal kidney growth in childhood, which is also not known. MRI is difficult or infeasible in children, and there is no validated progression marker. So now I'm going to show you some data that we did in Leuven in our pediatric ADPKD. They are almost all unpublished. So the first one is with Peter Selekens, who looked actually on the GFR, and we analyzed actually longitudinal data for more than almost 300 measurements, where we measured creatinine and cystatin C. And we went through all the available equation and we did a comparison. And actually, we demonstrated that actually the GFR, the yearly decrease of GFR in childhood is the percentage of the hyperfiltration is really dependent on the equation. So we think that a lot of study in pediatric are using the Schwartz with maybe an overestimation of the GFR. And we need to work as a pediatric community to validate the most available equation in pediatric research. Second, we are working with Luc Breysens and Frédéric Keizers from our pediatric radiology department. And actually, we followed since almost now 10 years 74 genotyped ADPKD patients, and we have almost 250 measurements. And we are using a novel method of 3D ultrasound because we think that MRI is really very difficult to use in very young children. And actually, we started by using the Mayo classification that is very known for all of you in adults. And we tried to plot our measurement in this classification. However, as you see, it is all started with one single point of neonatal TKV of 150 milliliters. Where we thought that maybe it is not adequate as children don't born with the same kidney volume, that they are percentiles, and we expect that actually the normal TKV of a child is less than 150 milliliters. So we adapt our initial TKV, and we made some percentiles. And we actually adapt our curves and developed a new model to evaluate the severity of or to stratify our patients in different category from actually birth till the age of 20 years. And you can see here that the trajectory for each patient might sometimes overlap, however, they stay in the same category. And thanks to Peter Harris, he gave me the chance to collaborate actually with the CRISP group, and thanks also to Alan Yu, who gave me actually the access to the data of the CRISP cohort from the age of 15 till 20 years, where we actually are adapting in our model, and we hope to work further together to extend the model and to work on a unified model from birth till adulthood. Then next, we have a huge biobanking of all these cohorts where we are actually analyzing early biomarkers, and a lot of research is ongoing. However, Peter Janssens during his PhD demonstrated that urinary MCP1 was increased very early in children, even with a very mild phenotype. We even evaluated some kidneys from termination of pregnancy of fetal kidneys with the PKD1 and demonstrated an overactivation of macrophage, showing that maybe inflammation is also a very early marker of ADPKD. And then we come to our very exciting adventure that I started in 2017 with Max Liebau, with his experience of ARPKD. We had this crazy idea to start an ADPKD registry. And we focused actually on ADPKD children because we had this indeed this very collaborative spirit in pediatric. So we based our registry on his experience of ARPKD. However, we adapted to the ADPKD manifestation. And since then, we approach a lot of centers worldwide. And thanks to Max and Franz, we succeeded now to have 91 centers from 33 countries, and we have almost 1,500 patients that we are analyzing. Then the story went further, and we actually are very pleased that the other registry from ADPKD, which were already ongoing in Australia, in North America, and in UK, and actually Lisa, Detlef, and Andrew joined this adventure, and we are aiming to join our forces to get this initiative worldwide. And we have now Angélique Dachy, who is now doing her PhD on ADPKD children, and we are writing our first paper, and she analyzed actually the worldwide registry, including at that time 1,329. And we are actually focusing now on the age of diagnosis, method of diagnosis, and genotype, and we are looking if there is diagnosis policies differences according to the geography, the era of the health economy. And actually, we were very surprised that the familial screening is the main cause of this population. So further, we worked on a consensus statement, including pediatric nephrologists, adult nephrologists, geneticists, and we made actually a management for ADPKD, and we think that the non-pharmacological management of children diagnosed or at risk are very important in childhood, because we know it is actually a severity factor in adults. This is very well described in the PKD International in Europe, but also in the PKD Foundation in USA. And we propose actually an algorithm where we try to differentiate the patients who are diagnosed or symptomatic with ADPKD, where we advise to do screening of hypertension and treating hypertension and proteinuria with ACE inhibition. For the ones who are asymptomatic but at risk, we really highlight that the need of discussing the diagnostic possibilities with the parents is very important, and to respect the family choice. Charlotte Jimpel just presented in the IPNA from this year the controversy via diagnosis or not of the ADPKD children, and I think the main thing is to screen for hypertension and life trigger. However, screening the patients, ultrasound or genetics needs to be discussed with the families. And last, because disease modifying treatment for ADPKD are really emerging in adults, there is now tolvaptan, which is already validated and for ADPKD with rapid progression. There is recently a trial in ADPKD children where we treated blindly tolvaptan or placebo, and we show that tolvaptan in childhood is effective by lowering the urinary osmolality, and we see also a very nice decrease of TKV, although it is not significant statistically, but it was not powered for this. And as last, I think the fact that there are new drugs emerging. So we participated in the PKD regulatory summit with different stakeholders and even EMA and FDA. And I think now that there is really a need, an unmet need in pediatric and young adult research, and to get a primary endpoint to start clinical trials. currently the CADIHO guidelines are also ongoing, and me, Melissa, and Max are there representing the pediatric voice of ADPKD. And then next to all my clinical work, we are working also in the lab, and I was very pleased to see that Sophie presented that sometimes using the urine of patients can actually lead us to a treatment in the disease. And we are actually now working indeed, although it is not the perfect cell lines, but it can give a really very nice information in ADPKD. So we are working in urinary very early stages. So I would like to conclude that we had made a huge progress on understanding ADPKD in children, that there is now enough evidence there is structural kidney disease and vascular dysfunction already in childhood. Screening for modifiable disease and implementation of lifestyle recommendations are now very important. So we would like to highlight that this family need really counseling and psychological support. And I hope that I convince you that the children and early stages ADPKD are novel and crucial targets for disease understanding and for novel therapy. And then I would like to thank the children of my ADPKD clinic that they made this kidney during day for ADPKD awareness. And I thank you for your attention.
Thank you, Djalila. That was really a wonderful, comprehensive presentation about all the advances made in pediatrics. It's very nice to see. So the first question for you is from Lisa. Do you think TKV is best corrected by height in children? Or given linear growth, would BSA be a more appropriate correction factor?
So we did actually the both. We did the TKV only on age, by weight, BMI, everything. But actually the fact that these children are growing, and what we saw is that at the age of 10 years, we see actually an exponential increase around the puberty, which might be related to growth hormone. And it has been now shown that growth hormone might actually increase the cyst formation. So, so I really believe that height adjusted is more appropriate than only TKV.
Very good. I think we are short on time, so I guess I give that back to Dr. Watnick.
Yeah, hi everybody. So we're a little over time, but I think we still need a 30-minute lunch break. So it's now just about 12:45. So we'll resume at 1:15 if that's okay. Okay, so I will see everybody back at 1:15. Thank you, all the speakers and all the moderators, and appreciate everything.
Thank you.